Good morning, everybody. Sorry about causing chaos earlier on. Martin asked me to come and talk to you, and I'll thank him for that and show you the mountains of Mourne, because I am from Northern Ireland, but we let Tim in for a wee while anyway. So what I'm going to do is to bring you up to speed on diabetic foot disease. I called it practice challenges, and then when I started to really work on it, I thought, well, there's so many practice challenges in working with the diabetic foot, so that maybe I should have called it red feet, because I'm really only going to talk to you about a couple of things. But just to highlight to you, no matter where you work, these patients are likely to come through your door with a problem, and you need to know what to do with them, even if you feel it's not within your clinical remit or your abilities to manage all that will come through your door. Diabetes has been described as the epidemic of the 21st century, and we know it's exploding. You would have to be asleep not to realise that the media have cottoned on to this and that it is becoming an epidemic. In the UK, the current figures are that we have 3.2 million people with diabetes, and by 2025 it's predicted that will go up to 5 million. And then you have what Diabetes UK described as the missing million, where there are 850,000 people who are walking about with undiagnosed diabetes as yet. And our average prevalence last year, well, it says 2014, last year's figures is 6% of our adult population, and the majority of those have type 2 diabetes. The complications of diabetes, there's a very nice paper by Marion Kerr estimating the costs. So from your cardiovascular diseases such as stroke and ischemic heart disease, down to the most expensive at the bottom, which is our business, which is diabetic foot disease, diabetic foot ulceration, and amputation costs $986 million a year. That's what it's costing. Expensive, not just from the point of view of hard cash, but also to the people living with diabetic foot disease from the point of view of their quality of life. It is a challenge, it's a global challenge. About 30% of those with diabetes have foot problems. That's, by today's figures globally, 73 million. And again, by 2025, 114 million people. So lots of diabetic feet out there for us all to try and manage. And I agree totally with what was said earlier on. From our point of view, and I work in Northern Ireland, we don't manage them mechanically well enough. We don't offload as well as we should do. And we know that. About 15% of people with diabetes will develop a foot ulcer during their lifetime. And that is about almost 37 million people. And again, by 2025, you're talking about 57 million people with a foot ulcer. And the recurrence rate is said to be about 70%. So if you come to anybody's diabetic foot clinic and you come back 6 months later, you think they're not doing a great job, that's that same person back again. Chances are they're back again with a recurrence. Oh, sorry. About 85% of all amputations are preceded, in relation to diabetes, are preceded by a foot ulcer. We have a very old document in Northern Ireland called the Crest Wound Care Guidelines, where despite all that went on in Northern Ireland, 60% of our amputations that made it to the rehab and limb fitting centre were as a result of diabetes. Not as road traffic accidents, not with our troubles, anything else, with diabetes. And in any 1 year, 1 in 20 of our diabetic population will develop a foot ulcer. So it's costly, and it's costly to the patient, as I've said. Problem is 1 in 10 of those ulcers will result in an amputation of a foot or leg. And the last figures I have said that to manage and maintain an amputee for any 1 year is about £60,000. Diabetes UK decided 2 years ago to launch the Putting Feet First campaign. Again, was very, very successful from their point of view. There were lots of TV clips on it. And what they produced from that was the 15 healthcare essentials, and one of them was the issue of your foot check, telling the patients they're trying to promote that those with diabetes take a certain amount, of ownership of their own foot care, and telling them that this is what they should have done. They should have their feet and legs checked for their circulation and nerve supply on an annual basis They don't dictate that it has to be done by a podiatrist because this is their screening guidelines, not their assessment. In Northern Ireland, and I think they're trying, Scotland certainly, anybody newly diagnosed with diabetes should have a proper foot assessment as opposed to screening, so that you get then, I'm going to have to try and find how to go back, where you sit within your category of risk. And these are readily available online. So you are assessed and you are told as a patient what your category of risk is, and hopefully somebody newly diagnosed will stay up there. I'm hoping now I don't wreck the pointer. And just need an annual review. But as their foot deteriorates, we come from low through medium, high, and once they have an active ulceration, then the real red lights are shining for them. And that was adapted from Scotland's traffic light system. So patients are well aware of what they should be having, and they should have that annual screening, and they should have had a foot assessment, and they need to say and be told what their category of risk is. So that's part of our duty of care as well if we're involved in that. I'm not going to insult you, but just to remind you about how diabetes affects the lower limb. You've got your nerve supply, your neuropathy damaged, and all that comes with that. There's lots of different versions of that. You've got your vascular disease and your risk of foot ulceration. But remember that the majority of these patients have a combination of nerve damage and vessel damage, and they have neuroischemic feet. So our second challenge after our challenge of assessing and knowing what's going on there clinically in front of us is, do they have infection or do they have ischemia when they present into your clinic with a foot like that? So, ischemia, peripheral vascular disease, or patients with diabetes have a high mortality when they have peripheral arterial disease. They've almost a doubled risk of death from those who have not had the opportunity of revascularization. And again, to harp back to our very old guidelines where we said anybody with an ABPI of less than 0.8 and greater than 1.2 should be referred to the vascular surgeons. Well, that was the majority of the patients with diabetes, so that has to have gone, and it has gone. So it's if they're presenting with signs and symptoms along with the ABPI. We don't tend to do ABPIs where I work because I work in tertiary care, so our patients tend to get duplex scanning and angiography. What has been shown through the UK PDS and the DCCT studies is that the good glycemic control will reduce the progression of their vascular complications, but it will not prevent them. Okay, those are old studies, but they're still very much referred to. And the other thing is that women are not spared the complications of vascular disease. They have between a 2- and 4-fold increased risk of developing vascular disease when you have diabetes. 30% of all patients with critical ischemia have diabetes. Their amputation rate, we all know it, has increased, and the mortality at 5 years is doubled. The disease pattern is very different in that the small vessels are involved, and some of you will have heard of extreme angioplasty and the work of Graziani, infrapopliteal disease, and the profunda femoris. 90% of patients with diabetes presenting with a foot like this, with an ischemic foot, ulceration or tissue necrosis or gangrene, are found to have surgically correctable occlusive disease. Get them early and get them managed if you can. And I know there's reorganisation of vascular services everywhere at the moment. Remember as well that your patients with diabetes and vascular disease will also potentially have the complications of renal disease and heart disease. And with that comes a tissue edema and the predisposition to ulceration and impaired healing. So it's the big package. Diabetes is often now described as a cardiovascular disease. Slightly off kilter for a wee second, but just to remind you about renal disease and diabetes and diabetic foot disease. Our patients are living longer. They're being given the opportunity for dialysis, and along with dialysis comes other risks. High risk of ulceration and amputation, and there are lots of studies to support those comments. And if you want references afterwards, I think you're putting this all, that it'll be available for people. If they require a bypass, they have a 5-year mortality approaching 95%. Renal disease and diabetes and diabetic foot disease are not a good package. And what also has been found is that about 6% of patients with diabetes have an amputation within a year of starting dialysis. And then clinically, there's a lot of debate between the vascular surgeons and the renal physicians over revascularization or amputation. The renal physician may want to preserve the kidney and the vascular surgeon may try to want to preserve the limb. So you sometimes get involved in all of that as well. And the other issue is feet like this from the point of view of a clinical management. And the fact that that calcification of these distal vessels can end off with this horrible heel necrosis, especially if posterior tibial is involved. The pain there is dreadful for these patients. The clinical management is dreadful from the point of view their pain, debridement, and how you offload that foot with the whole package of life and dialysis. These patients are a big, big challenge. The other thing is transplants, and more people are having transplants, and transplants from the live donor. But amputation is the most common complication of vascular disease and renal disease after they have a transplant, with up to a quarter of all patients having that within 5 years of their transplantation. So transplants do not cure all their problems. So back to these neuroischemic feet, the feet that have not just vascular disease, but also the nerve damage, and it's the combination. The absence of pulses, just your straightforward palpation of pulses, doubles the risk of amputation. Okay? And if those patients present with an ischemic pain, that is also a poor prognostic sign for those patients. And they do come through your door. Vascular disease is associated, obviously, with non-healing ulcers. It's a causal factor in about 50% of our amputations. And the problem is, because they have neuropathy, because they have that nerve damage as well, when they present, they potentially will present with a loss of tissue or tissue necrosis as the first signs of vascular disease. They won't have the pain of claudication. And when they're presenting clinically with rest pain, tissue necrosis, they're quite far down the line of disease process. Management. If you catch them early enough, if you identify them, and if you get them seen by your vascular team, if you've got a friendly vascular team, then you're on the pig's back. If you catch them early enough and they can be revascularized, and they don't tend to go straight in for your actual vascular surgery of bypass and such, like a lot of radiological interventions take place now. So we have our angioplasties and our stenting before they need a bypass, because you can only have one bypass and then it's amputation, is what our vascular surgeons say, whereas they can have several interventions by the interventional radiologist through the angioplasties and then the bypass. The vascular surgeons, and I'm not a surgeon, and there are people much more learned about surgically managing diabetic foot problems than I am in the room, but they will tell you that they assess sepsis and ischemia to provide drainage and debridement. They are involved in wound management, some more than others, for revascularization and amputation. That's what they see their role as. And vascular surgeons, I think, have now accepted that they do have a role in managing diabetic feet, most of them anyway. So is it all about what are they going to do first when these feet present with them? Are they going to drain the pus? Are they going to debride the necrotic tissue? Are they going to revascularize? What do they do first for these patients? Some diagnostics before anything, if possible, I think. But it is important to provide drainage. And as I say, these are vascular surgery slides. They're certainly not what I do in a clinic. But providing that drainage and then having another look at those patients, taking that foot out of that crisis, out of that risk. And they'll tell you that their indications for revascularization are things like rest pain, tissue necrosis, and uncontrolled sepsis. And equally so, they will tell you that patients end off with an amputation, be that they are neuropathic, ischemic, or they have infection. If they have tissue necrosis and rest pain, it may be that pathway to amputation. And amputations are not always the worst outcome for somebody with diabetes. And then you have your bypass that works for a certain amount of time. She's lost her toes as well, and she presents back at clinic. And this lady, unfortunately, her carer had been on holidays and she didn't want to bother the girl who was covering. So she suffered this for a week before she came up to clinic, and she ended off with an above-knee amputation. Okay. So it's all about picking up the subtleties of vascular disease and identifying and shouting early and loud, rather than sitting on things and trying to manage things for too long. Get yourself known to a vascular surgeon or a team that can access them, and get these patients seen sooner rather than later. So the second challenge, the third challenge we've assessed, we're trying to identify and pick up the subtleties of vascular disease, is infection. And I think this is one of the big challenges in diabetic feet, and this is an old quote. Some of you will know who Ali Foster was, but to never underestimate any lesions on the foot, no matter how small a foot wound is. You have a portal of entry there and the risk of infection. And this slide's a very, very old one, because I am very, very old, but this was a young lady. She was 27 and she picked the hard skin on the sole of her feet, and a relative walked in and said, "What is that smell?" And you can see, if you're awake and still with me, and I changed the slide, that extended through to the dorsum of her foot. And all she'd done was pick a bit of hard skin on the sole of her foot, but she'd broken that tissue and ended off with an infection that was quite destructive. Okay, and those slides were taken a couple of weeks after hospital admission in the old days. So remember, small things can cause big problems. There's a nice paper, it's an older paper by Mike Edmonds, about the myths of diabetic foot disease, and I want to throw two of them up at you. And one is that infections always present with the classical signs of infection that we all learnt a million years ago as students, and they don't. You may not have that erythema, and you may not have pain. Neuropathy will dampen that all down for you, and you will have your failure of that vasodilation. Ischemia will also lead to that absence of that redness in the tissues. And there is this immunopathy that still needs a lot of research done, but it's there, and we know that it prevents abscess formation. At times it limits it compared to what you or I as a healthy individual would have. And the signs of the classic signs of systemic infection, of being really unwell, quite often these are damped for a time. Often there is no increased white cell count, there is no fever. When the patient comes to the chair, the wife's usually with them, because it tends to be men rather than women that get diabetic foot disease, saying, rattling and rolling around the bed and the sweat dripping off them sort of thing. Then you know you've got a patient on a foot that is in real danger. It's a poor indicator of acute osteomyelitis. And over half of our patients with an acute osteomyelitis, in fact, research evidence shows that they had normal white cell counts. And that's from work by David Armstrong. So just be aware that these patients, when they have a foot infection, quite often don't think there's a lot wrong. And you're thinking, well, actually, my big thing's biomechanics, and none of these patients are ever really going to come across my door if you don't work in the high-risk foot world. But he went to the local podiatrist because he thought he had bruised his toe. He worked at Sainsbury's. And he thought he had bruised his toe. He had been diagnosed with diabetes, but thought it would go away. And he arrived down to the local podiatrist to see could they sort the bruise around his nail. Lovely example of a nice infective necrosis for you there. And I don't think he had a bruise under his nail. As I've said, made a squiff of that slide, 6% of our population have diabetes. And about 15% of them, we've said, will develop a foot ulcer. And of those, between 40 and 80% have an infection or a suspected infection. And there's the whole thing at the moment of trying to get people to move away from swabbing these wounds and getting in there and sending our microbiology labs, preferably fresh tissue, and better still, a squirt of pus as well, if you can get it. but don't send them just a swab that you've taken out of a packet and run across the dorsum of a diabetic foot wound. They don't want that. They'll tell you trash in, trash out. And equally so, if you are sampling diabetic foot wounds, our practice is that we tell the labs it has come from a diabetic foot. 40% of these have a mild infection. You think, she's really gone off it now, but I'm going to talk to you about these categorizations of infection in a minute. You have 40% of them with mild, 30 to 40% have the moderate infection, and 20 to 30 will have a severe infection. And these terminologies at the bottom come from the IDSA guidelines on diabetic foot infection. Okay? And those were updated in 2012 by Ben Lipsky and his team, and they matched it up to PETAS. So, right at the top we have uninfected, which we're not going to talk about, but I'm going to quickly have a look at how they categorise mild, moderate and severe, because it's a whistle-stop tour for you. Those are their basic descriptions on what a mild is. It's a 2 centimetre radius or less of cellulitis around your wound. There's no deep tissue involvement, there's no tissue necrosis, and the patient feels well and the foot is well perfused. They then have their moderate and their severe. And clinical pictures are much better than anything I can say. So back to that of your 2 centimetre radius, no deep tissue involvement, no necrosis, systemically well and a well perfused foot. And a little pocket of pus with that erythema around it. Mild. Whoops. Your moderate infection, you have an erythema or a cellulitis of greater than 2 centimetres. You may now be going down into your superficial fascia. You may have your tendon involved. You may have bone involved and the joint. There may be abscesses, but the patient still feels well. So feet like this are a moderate infection. And some of you might think, oh, I'd break out in a sweat if that came into my clinic. The one on the left, just for those who are interested, was a hot water bottle burn. We were managing his right foot, and this is our other tip, where he had had his first and second toes amputated as a result of necrosis that he had sat on, a foot infection, and ended off losing 2 toes. That was the outcome for him. And he arrived up at clinic looking very, very sheepish, and he says, Jill, I have a confession. I says, what's wrong? He says, I took a hot water bottle to bed and it burnt my other foot. Okay, and this is about 6-8 weeks afterwards, and he has ended off, I saw him on Wednesday, this is Friday, I saw him on Wednesday and he has lost his first and second toes, and he is now thankfully healed. And the one on the right, I think you'll all know, is a nice Pseudomonas infection. Likewise, your typical sausage toe of your osteomyelitis on your right third there, and this gentleman on the right thought his diabetes would go away. Didn't do anything about it, and about 10 years after diagnosis, arrived at a GP practice one day with a foot like that. But it's still a moderate infection because he didn't feel ill. The wife just said the stain on his sock was getting a bit too much to have to wash every day. And that is the problem. And then you've got your severe, which is exactly the same descriptors as a moderate infection, but the patient is now feeling unwell. They have their rigors, they're rattling around the bed, their sugars are all over the place, and they're medically unwell. So they're presenting with something like that, which started off actually with this gentleman as a little fissure between his toe. Okay, but he was unwell. Likewise, that's not going to project very well. I think over. That lady fell out of her wheelchair and scratched her toe, but went on her week's holiday. She didn't want to miss the holiday and came back with a foot like that and feeling very unwell. So your challenge is identifying the differences between a foot that's infected or ischemic, or indeed that you have both. Okay? And I found this in a nice paper which said these are the sort of things you should be looking for: that change in tissue, those bluish patches, the little blood blistery type bullae, tissue necrosis and extensive cellulitis. So that's just a wee reminder for you. And ischemia or infection, which have you got there? What have you got there? Have you got both? Well, on the left you have both, and on the right you have ischemia. But it's just to remind you, you need to look, you need to assess, and you need to move. No matter where you work, your trust should have antibiotic guidelines. These belong to Belfast, and they're based on those IDSA criteria of your mild, moderate and severe infections. And another challenge, and I'm whistling, this is one of my heroes. He's not in the room anyway. This is Ben Lipsky. who led the IDSA guidelines. And is it infection sitting now in front of you, or is it Charcot? And Tim's French is much better than mine. So your Charcot feet, very quickly, what's going to arrive with you? Well, Charcot feet aren't just found in patients with diabetes. These are some of the conditions it's found in. Charcot was a neurologist, but we most commonly see it in our world in patients with diabetes. If you're working maybe out with patients with leprosy, that could be a different story. Leprosy, diabetes, and chronic alcoholism. And then you start to search your literature, and those are just some of the terms that will be within the literature, all describing the Charcot foot. So what has been suggested with this very nice paper that was published in Diabetes Care a few years ago was that we should all use the same terminology, and then we can all start to gather information, which is either to call it Charcot neuroarthropathy or the Charcot foot. So what is it? It's a progressive condition of the musculoskeletal system characterised by your joint dislocations, pathological fractures, and debilitating deformities, if you want a one-liner on it all. Massive joint destruction if you don't identify these patients early enough, and indeed it can result in an amputation. The prevalence, it depends where you are and who's gathering your data. It can be anything from 0.1% right up to 13%. And Ben Lipsky's one hero, and the other one is William Jeffcoat, who will tell you, as a general practitioner, if you're a GP working in a GP practice, in your lifetime as a GP, you will have one patient with Charcot come across your door. So it's important that you know what you look for early, even if it's only that once that case comes through your door. The incidence of acute Charcot of the foot and ankle can be anything from 0.15 to 0.25%. And the recurrence rate is less than 5%. This is an area we still need to do lots of research in. It's a destructive arthropathy. Patients have a loss of their protective sensation. Predilection of 3:1 for men. Median age, people in their mid-50s, men, type 2 diabetes, poorly controlled. Not against men, but 30% of them bilateral. And the other group, well, there's two groups, are our renal transplant patients again, and our young women with type 1 diabetes with an eating disorder. This disease has been described by some people as being similar to an osteoporosis. So it's just worth remembering that as well. And there are lots of different versions of this available, and I'm not going to talk about the pathogenesis. I'm not the best person to do so of the Charcot foot. But there are a couple of theories as to what causes it. You have your neurotraumatic and your neurotrophic theory, the German and the French, as to what exactly causes Charcot. Is it to do with nerve damage? Is it to do with damage to the blood supply? Is it both? What is going on there? But a nice paper by Jeffcoat, Peter Kavanagh and Fran Game a few years ago now in the Lancet suggested that the central point was actually an inflammation, an inflammatory process. And this slide belongs to William Jeffcoat, and you have your French theory and your German theory, and then their theory, which is referred to as rank L. Okay? And you could have a full lecture on that, but it's just, that's the theory to the etiopathogenesis, and that the bottom line is, very early on, you'll get an inflammation. But it's picking these patients up. The clinical associations are long duration of diabetes, the dense peripheral neuropathy, the fact that these are your feet potentially with that bounding pulse that you relate to your autonomic neuropathy. The other complications, such as your renal transplant patients, there's an active bone turnover there. Patients, one of your differential diagnosis is bone fractures, ruling out fractures, but they also tend to have fractures in their other bones. And again, those eating disordered women. Clinically, when that comes into your room, it will tend to be a unilateral, red, hot, swollen foot that is swollen up quite rapidly. If you're lucky, the patient may also be able to tell you that they tripped over a paving stone, or they tripped climbing up a step, or they fell over the grandchild's Lego. A micro trauma, they now realise, is linked potentially to Charcot. And the other trauma, and we'll talk about it again in a minute, is sometimes a surgical intervention, and I'll give you the reference for that one. They're usually painless or moderate pain compared to to the swollen foot in front of you, and you're looking for a temperature difference of more than 2 degrees. And your hand will usually pick that up. We use a dermatemp. And then your differential diagnosis, your cellulitis, your DVTs, your osteomyelitis, your fractures, your septic arthritis, your gout, your phlebitis. Get it all ruled out to make sure that it's a Charcot. We tend to use this, and it's far from perfect, and I'm sure other people have better, but from the point of view of their bloods, their alkaline phosphates done, their CRPs done, their uric acids done, their ESRs done, and their white cell counts done. That's standard with us, that the patients have those blood tests done to try and help us make a differential diagnosis. And then primarily an X-ray. We don't have urgent access to MRIs, but MRI is still seen, I think, as the gold standard for picking up those subtleties in the tissues. And as I say, there's other people better placed to talk about all that than me. But MRI will allow you the anatomic imaging of your area and to distinguish, we hope, between osteomyelitis and Charcot, and the sort of signs that you're looking for, your ligamentous disruption, your joint deformity, centre for the signal enhancement as to what's going on there, and also Doppler ultrasound sometimes done to rule out a DVT. I've never had a patient where it has been a DVT rather than a Charcot, but never's a long time. And the stages of Charcot, if you believe what Jeff Coate and Kavanagh and Game have said, that inflammation is that first thing, if you pick it up subtly enough. There's an acute onset, which is what I've described as what the patient potentially would present with. You have your bony destruction then that goes on, and then consolidation. And you can see that's nicely consolidated pair. The Antiques Roadshow would love you for that. And the radiographic staging that's still referred to is there for you. It's an Eschenholz system of picking up the different stages. And plain X-rays are still deemed to be okay. MRI is better, but you can use your plain X-rays to sort of monitor the disease process to some extent, and we do that. And your management is to pick it up early and get that foot offloaded. Preferably a total contact cast. If you don't have access to that service, then something like a Crow, which is your Charcot replacement, orthotic walker. I personally wouldn't wear one. It looks like something that Herman Munster or somebody would wear. Bisphosphonates have been in fashion, out of fashion, in fashion, out of fashion, and the CD UK study that Fran Game and William Jeffcoat led, which was basically an audit where people logged in and registered their Charcots and they were followed through, said patients who were managed with your bisphosphonates stayed longer within the disease process. So people have moved away from it a little bit. Orthopaedic surgery, if you believe in it, was stabilisation, pins and plates, and amputation if you haven't picked these patients up early enough, and they end off like my friend with the pair at the front, with bilateral consolidated joints that are taking pressure. And sometimes, again, the best outcome for somebody like that, not necessarily him, when you've that gross deformity that persistently ulcerates and you can't get that foot remodelled, is an amputation. So your weight bearing, get them non-weight bearing as soon as you can. Even if you think your guts are saying it's actually an infection, get them off it until you make your diagnosis. Bracing, whatever. We're trying to move away from air casts. There are patients that they fit and patients that they don't. And the whole thing of management of ulceration as well, if you have it. They don't all by any means have an ulceration. And your surgical treatment, only considered after all conservative measures are exhausted. I don't know what the thinking in the room is. We have an orthopaedic surgeon in Northern Ireland at the moment who thinks that he can intervene while Charcot is still in its active stages. I'm not taking them on. Surgical intervention can be necessary, and it can help to remodel that foot so that you have something that is functional and not taking pressures, so it won't be as likely to ulcerate. But of course, offload that foot. Offloaded shoes, insoles, that's your world, less mine. There he is, William Jeffcoat, hero number 2, hero number 1. Final message from him about Charcot. If someone comes into your clinic with a red hot foot and you're thinking of a sprain or a cellulitis or a DVT, just check whether they have diabetes, whether they have neuropathy, and get the weight off that foot until you make your diagnosis of Charcot. And if you don't know what you're doing, don't be afraid to put your hand up and get in touch with somebody quickly who you think does know what they're doing, rather than holding on to this until it's too late and damage has been done. I think it's a very nice message. That comes from that paper I referred to, where they were asking us to all use the same terminology for Charcot. I'm not going to sort of go through it all, but just to say, make your diagnosis and get that patient offloaded and appropriately managed. The process, they reckon, takes between 9 and 12 months to get to consolidation. Less time if you offload them and don't use bisphosphonates, according to that audit by AIM. But the other side of it is, if you don't manage it appropriately, and this comes from an old book by William Jeffcoat and Ros McFarlane, if you don't manage these patients, they end off with a grossly deformed foot very, very quickly, that you then have a point potentially of no return. And if you want further information, there's a nice site, which is the Foot Ulcer Trial Unit site, where there's a nice sort of 12-page document on Charcot that you can readily download. I actually give it to some of the patients. If you go into the foot ulcer, if you just type in Foot Ulcer Trial Unit, you'll very quickly come to that, and that is one of the resources that's still there, because it's quite an old site now. So is it Charcot? Is it infection? It's a big practice challenge, and it's getting it right. And very, very quickly, a case study for you of somebody who went to a local hospital with a red hot swollen foot. He was a diabetic, and saw a general surgeon who decided that he had a necrotizing fasciitis, and opened his leg from his pelvis to his malleolus to drain this fasciitis, or this necrotizing fasciitis that he thought he had. In fact, the patient had an osteomyelitis of their second toe. They were eventually referred up to the city hospital, and they had surgery, and he was sent home, having had drainage and amputation, and presented back to the same hospital who had opened his leg for him with a red hot swollen foot again, and they sent him straight back up. And he was admitted because we were concerned as to what it was, whether it was an infection. That's where the drain was, just in case you wonder. He had had the toe amputated. You see, that all healed nicely. There's still a little area there where the drain was as well, surprisingly. I saw him 2 weeks ago, and this is the bottom end of his fasciotomy wound, still hasn't healed. But he actually had both a Charcot and an infection. So again, I said about ischemia and infection, and you can have both. You can also have a Charcot and an infection presenting together, and then it's getting through the wood to see the trees, to see what you've got and how you should manage. And you'll be glad to hear I've finished, having rattled on for too long, with 2 quotes, and I thought, well, I take one of them out, and then I thought, no, one mistake made for not knowing, you'll make 10 mistakes for actually not looking. And the one thing I didn't say that I meant to say was, when you're managing diabetic feet, take both shoes and socks off at all times. It's one we all learn by a mistake somewhere along. And you see what you look for, and you'll recognise what you know. So someday somebody's going to come into you with a red hot swollen foot, and just, if nothing else, remember your woman that rattled on said about Charcot. And that's our Giant's Causeway. Thank you very much. Thanks, Martin.